All right, very good. Good afternoon, everyone, and thank you for joining us for Grand Rounds today. Today, I have the distinct pleasure of introducing our speaker today, Dr. Ira Jacobson. Dr. Jacobson graduated Alpha Omega Alpha from Columbia University College of Physicians and Surgeons. He completed internal medicine residency at the University of California, San Francisco, then fellowship in gastroenterology at Massachusetts General Hospital. He's held positions at Weill Cornell Medical College, where he was the Vincent Astor Distinguished Professor of Medicine, followed by Icahn School of Medicine at Mount Sinai, where he held positions as Professor of Medicine and Vice Chair in the Department of Medicine. And finally at NYU for the last 5 years, where he's currently a Professor of Medicine at NYU School of Medicine and Director of Hepatology at NYU Langone Health. Dr. Jacobson has over 400 peer-reviewed publications, particularly in the field of viral hepatitis. He's currently principal investigator of multiple ongoing randomized controlled trials, and he's held national leadership positions in several gastroenterology and hepatology associations. We are truly honored to have him here today. So please, everyone, give a warm welcome to a leader in the field of hepatology, Dr. Ira Jacobson.
Thank you so much, Robert. I'm very honored to be here with you today. I'd like to thank my colleague, Paul Martin, and Dr. Weiss in the department for inviting me to give this talk. In all transparency, Dr. Martin is one of my dearest friends, and I may pay homage to him a little bit during the talk in a couple of ways that you'll see. Hepatitis B has always been the liver disease that excited me more than any other, and I'll hope to share the flavor of that passion with you today as I talk about new developments related to the biology of hepatitis B, our knowledge of its clinical course, current treatment, and some future treatments. Most of these disclosures don't have anything to do with hepatitis B, but they're all here. I'm an investigator and consultant for a couple of these companies regarding hepatitis B, including Janssen and a couple of others. Now, this is a global map that, if you compared it to a similar map a few years before, would show that we actually have made considerable progress in reducing the prevalence of this extraordinarily common infection around the world in those countries, or some of those countries at least, like China, where it's been highly endemic, perhaps for millennia. This shows the relative frequency of the hepatitis B antigen positive state, most of which reflects chronic hepatitis B infection in different parts of the world. And as you might expect, the red areas are those with the highest prevalence, where the population that harbors hepatitis B surface antigen is over 8%. In the past, all of sub-Saharan Africa and pretty much all of Asia would have been colored red. And the big dent here has been made not so much by therapeutic advances, much as we'd like, but equally importantly by early life vaccination. And we're not going to talk too much about vaccination today, although I'm happy to take questions about it later. These are the countries that account for 80 or more % of the total HBsAg positive worldwide infection burden. And you can see that China still leads the list, as it always has, to our knowledge, with other countries following, including Nigeria, which is third. But you'll note that when this particular study looked at populations aged 5 years, Nigeria led the list and China's way down here. And that again testifies to the effective implementation of infant vaccination in the parts of the world where the prevalences here in the younger population are much lower than they might be in the population overall. We still have, in other words, a long way to go, but we are making progress. Hepatitis B is like hepatitis C. It has genotypes. So in the case of hepatitis B, they're designated by letter, with the numbers indicating subtypes. And this is not going to be a clinically important theme throughout my talk, because in reality, we can manage hepatitis B pretty well without knowing the genotype, though aficionados like Dr. Martin and me, and perhaps some of you, do get a genotype. It can tell you a little bit about the likelihood of response to interferon, because genotype A, which is the closest thing to being the indigenous genotype in the United States, as opposed to indigenous immigrant populations, is more responsive to interferon. So in the older days, when we used interferon more than we do now, you really couldn't adequately inform the patient about the chance of response to interferon without knowing the genotype. It also is a truism that genotypes B and C are the dominant genotypes in Asia, And we've come to understand that for whatever reason, genotype C seems to be a little more pathogenic in the sense of being more likely to be associated with progressive fibrosis, cirrhosis, and liver cancer. And every once in a while, we might make a therapeutic decision if somebody is otherwise in the gray zone, as I'll show you later with regard to candidacy for therapy, to treat a genotype C patient as opposed to a B patient with all the other same criteria. But that doesn't really arise very often. I've always believed firmly that you have to understand this virus to understand the disease as well as the serologic markers that we all use. And this has for a while been the most attractive picture that I could find that outlines in schematic form the structure of hepatitis B, which is a member of a family of viruses called hepatitis DNA viruses or adenoviruses. These are astonishingly widespread in nature. Woodchucks have a very similar virus, and the woodchuck model has been key, particularly early in the hepatitis B era, back in the latter part of the 1900s, in helping us to understand the biology of human hepatitis B, Peking ducks, ground squirrels, herons, and others. So probably the phylogeny of this virus goes back a very, very long way in time. The virion itself has what we call the hepatitis B surface antigen, which actually comes in a small version, a medium version, and a larger version, inside of which is a core antigen, which is the inner shell, if you will, structurally vital to the virus. You can't have a virion without either the surface or the core antigen. And the E antigen, which I'm going to talk about quite a bit in a few minutes, is the secretory counterpart, if you will, of the core antigen, derived, again, as I'll show you in a moment, from much the same portion of the genome, but processed a little differently, and is sort of the secretory counterpart of the core antigen. This is very important because we'll be talking about a vast division of our chronic hepatitis B patients into two, those who are E antigen positive and those who are E antigen negative for reasons that I'll show. Then we have this fascinating, partly double-stranded DNA genome. Nobody really has explained, as far as I can tell, what advantage to the virus is for having this partial single strand of its longer strand, which is embedded in the double-stranded helix. But in any event, that is the structure of the virus. And the life cycle of the virus is something I want to dwell on for just a moment. We really have a lot deeper understanding of this than we used to. And as you'll see, it'll play very much into our subsequent discussion about how we think we should be managing this disease and how we should perhaps be developing new therapies to finally conquer this disease. We're currently in a state, as you know, where we're very good at suppressing viral replication, or as I tell my patients, making the bear hibernate for as long as we want it to, where it can't really hurt you, but we don't know how to get rid of it completely, unlike hepatitis C, a really stark contrast to another virus that we've been dealing with for many years. We've made enormous strides. Hepatitis B virus enters liver cells predominantly through a receptor called NTCP, which is the body's major bile acid receptor. The mere discovery of this virus was actually a great development in the history of hepatitis C. It was made in China and published about 9 years ago, back in 2012. The virus is uncoated. That outer shell of the surface antigen comes off, and you have the inner capsid with the core antigen on the outside, the core protein. And then, of course, the inner contents of the genome and the associated DNA polymerase that I didn't mention before. The virus enters through nuclear pores into the nucleus, where it is uncoated completely. And one of two important things can happen to that, what's called relaxed circular DNA. It can either complete that hitherto incomplete single strand, becoming a completely double-stranded genome, whereupon it becomes supercoiled, as the scientists say, forming what is really foundational to the life cycle of the virus within infected cells, covalent closed circular DNA, or the famous cccDNA that we always talk about. But another potential route, which is a replicative dead end of the virus, unlike cccDNA, from which everything in the viral life cycle subsequently ensues, but can also integrate into random portions of the human genome. And we're going to talk a bit about integrated DNA today and its potential consequences. It's really from the CCC DNA that the 5 messenger RNAs of the virus arise by transcription and are exported to the cytoplasm. And the first thing that has to happen to perpetuate the life cycle at that point is the formation from core protein, which then aggregates to form a 128 molecule polymer of core protein called the capsid, within which replication occurs. And replication can't start occurring until that is enveloped within a complete capsid, which you see here. And it is the longer strand of the DNA that serves as the template for what happens next. That DNA arises from the pregenomic RNA, which is one of the 5 major messenger RNAs of the virus. So if you're already thinking retrovirus in your head, there is indeed an analogy, at least with regard to this theme, between retroviruses and DNA. So again, since I didn't make it clear before, one of the 5 pivotal messenger RNAs is pregenomic mRNA, which by reverse transcription within a capsid, and that's really the point I wanted to make, becomes a single-stranded DNA from which the shorter strand is then transcribed from the longer DNA. And now you have that relaxed circular DNA, and it gets processed by the Golgi apparatus and perhaps in other places becomes enveloped with HBsAg and then is secreted into the blood from the liver cell. But a little bit of it recycles, providing replenishment for what would otherwise be slow attrition of that treasury, which is very important to the virus, of stored up relaxed DNA, which you need to replenish your CCC DNA. And some people think that if we can interrupt this recycling process as well as the formative process shown here, that might be one way we can potentially develop novel treatments for hepatitis B, more about which in a little while. One very exciting recent discovery that I want to share with you that's really kind of blown us away, to use a colloquial phrase, is that hepatitis B surface antigen doesn't just arise ultimately from one of the messenger RNAs formed from the CCC DNA in the way that I just mentioned to you, but can also arise off the integrated viral DNA. Now, importantly, I said a moment ago that the integrated viral DNA is a replicative dead end, and that's true. It cannot give rise to whole viral particles, but we know that enough of the genome does get embedded in the integrated DNA to be transcribed and then translated into hepatitis B surface antigen, something we did not recognize till about 5 years ago. And we've subsequently learned that the species of hepatitis B surface antigen, or at least the origin of the surface antigen that dominates in E-positive patients who are generally earlier in their chronic hepatitis B natural history, is from CCC DNA, but in E-negative patients who are generally chronologically later in the disease course, much or most of it arises from integrated DNA, which does pose a challenge in terms of how we achieve functional cure if, as we are currently doing, we're defining that as HBsAg clearance in the long term. We have lots of ideas about how to get rid of HBsAg coming from CCC DNA, amongst them therapies like CRISPR in the more distant future that might get rid of all the CCC DNA, but we really don't know how we can go about eliminating the integrated DNA, because after all, that's embedded in the human chromosomes. And we may not even have to, because it is a replicative dead end. And we'll get into that just a little bit more later. These are the 4 open reading frames of HBV. It's one of the simplest, most economically packaged viruses, certainly DNA viruses in nature. As I said, 4 open reading frames that ultimately lead to the surface antigen, the polymerase, this core and pre-core portion, which are adjoined, and then a mysterious protein that we're learning more about called the X protein comes off this part of the open reading frame. I want to emphasize again, as this footnote says, that this is the source, the pre-core and core portion of both core antigen and E antigen. And this shows further the difference between the two, which is that the E antigen comes off a longer portion of the mRNA that comes off the DNA in the first place. And the core antigen takes advantage of the fact that there are 2 start codons here. This is the first one, translation of which from the messenger RNA results in the pre-core, in the hepatitis B E antigen, which is that secretory counterpart of the core protein that I told you about before. But if the process starts from this start codon, you get the structurally vital core protein. And this stop sign here shows you the biologic basis for e antigen negative chronic hepatitis B, as does this yellow arrow. It turns out that there's a common mutation that occurs with a single nucleotide substitution right here at the 1896 position that forms a stop codon and renders the virus unable to make ongoing e antigen. And this is called this dual set here, which tend to occur together, are called core promoter mutations that don't form a stop codon in either case, either position, but markedly downregulate the synthesis of e antigen. So our patients who've evolved e negative chronic hepatitis B in the later phases generally have been infected with wild type virus, but have over the course of time developed in their viral genomes one or the other or both of these two sets of mutations here. And that will help you understand this division we make between E negative and E positive disease. The X protein has been a mystery, and theories about what it does abound. It is a transcriptional transactivator, which has been very interesting to people who investigate the pathogenesis of liver cancer in hepatitis B, particularly that which arises off integrated DNA, as we now think. But the hottest theory right now for what X may also be doing is interfering with something called this SMC56 complex that is a natural product in our cells and actually suppresses CCC DNA transcription, which is good for the patient. But what the X protein does is it forms a complex with other proteins that leads SMC56 toward proteasome-mediated degradation. And what the X protein does with these other two cofactors is it ubiquinates the SMC56, which is trying to protect the patient from CCC DNA activity, so to speak, and results in it being degraded. So some people now think that targeting the X protein may be another even more novel pathway toward new therapies than we've already been investigating. Now, the clinical course of hepatitis B is shown in this picture, and I'm sure you've all seen this in medical school and beyond in one stage or another. I'm going to talk very little about acute hepatitis B today, but just to remind you, that disease is characterized by a transient appearance of surface antigen and almost always e antigen. And remember, always check an acute hepatitis patient for IgM anticore, because occasionally in patients with acute hepatitis B, particularly more severe cases, the surface antigen can clear very quickly, and the only marker may be IgM anticore that the patient sitting in front of you has acute hepatitis B. So for any patient with acute viral hepatitis or suspected acute viral hepatitis, always add an IgM anticore, which I suspect you're doing. The surface antigen clears in these patients, resulting in the appearance of, or followed by the appearance of anti-surface antibody and long-term presence of total anticore. Importantly, the presence of anticore antibodies does nothing to tell you whether somebody has acute or chronic hepatitis B or even resolved infection, because it persists for life. The serologic pattern in chronic hepatitis B, in contrast, is characterized by definition as long-term persistence of surface antigen, long-term persistence, though perhaps not indefinite persistence in all patients, of e antigen, which is associated with much higher levels of viral replication. Long-term, the appearance of E antibody, particularly if you clear E antigen and become an inactive carrier, or for that matter, if you go in another direction and clear the E antigen, but still have active viral replication with those mutants that I told you about that result in E negative chronic hepatitis B. And these are the phases of chronic hepatitis B, starting with, at least in patients who acquire this in infancy, though much less in adults, an immune tolerant phase. I would remind you at this point that it's the immune response to hepatitis B that causes the liver damage that results in the disease called acute or chronic hepatitis B. It's not a cytopathic effect of the virus. So immune tolerance, which infants get if they're infected perinatally or very early in childhood, is characterized by very high levels of viral replication, characterized by high levels of HBV DNA, generally high levels of surface antigenemia, and very low or normal levels of ALT, because the immune system is in a permissive state. It's tolerating the infection, so there's no liver cell damage, and at least during this phase, little or no progressive fibrosis. Then we enter a phase that I prefer to call the immune active phase, though many references like this one, which is otherwise a nice graphic depiction, still refer to it as immune clearance because the immune system has activated in an attempt, if you will, to help clear the infection. It just doesn't usually happen, although in some lucky patients it does. And during that phase, you can have fluctuating levels of surface antigen, of DNA, but generally high levels of ALT because it's the immune reaction or activity that's causing the liver cell injury. Then about 10% of E positive patients who've been in this phase for a while clear the E antigen positive phase. And with that comes a stage of viral quiescence, characterized by what we call the inactive carrier state when surface antigen is still present, but the E is gone, the ALT is normal, and DNA levels are either very low, say below 1,000 or 2,000 international units per mil, or actually not present at all. If, however, the patient has already archived the mutations that I've talked about, you can reactivate with E-negative chronic hepatitis, or you may transition directly from E-positive to E-negative disease and bypass the inactive carrier state. And of course, the best stage of all is resolution, which once you have chronic hepatitis B occurs in a small but not insignificant number of patients, eventually characterized by clearance of hepatitis B surface antigen as well. It's resolution that we're trying to accelerate the progression toward with the development of our newer therapies, on which I'll close in a little while. Now, I think everybody here knows the potential sequelae of hepatitis B, and I'd ask you to forget the numbers here. You can peruse these later if you wish, or get them in any reference. But the point is that chronic hepatitis B can all too often result in cirrhosis, generally over decades rather than years or certainly months. That in itself can lead to liver cancer, but you can go to liver cancer from chronic hepatitis B and bypass cirrhosis, which makes hepatitis B a bit different from most other liver diseases, where the prerequisite for getting liver cancer is developing cirrhosis first, not a viral infection, although hepatitis C has that same property that you generally have to have cirrhosis to get hepatitis B, and to get hepatoma. Now, it can also go to liver failure through cirrhosis generally, and of course, a number of patients every year in this country get transplanted. It is tragic to me how often we see patients put up at our weekly liver radiology conference or tumor board who have incurable HCCs because their disease has never been recognized or managed. And this is really an avoidable tragedy on a massive scale, both globally and even to an unfortunate extent in our own country. That's what we're trying to prevent. There are two pathways, as I've already hinted, to HCC and hepatitis B. The first is the years of necrosis, regeneration, and fibrosis, similar to anything else that can cause cirrhosis, whether viral or not. And that in itself predisposes to liver cancer. We don't really understand fully the biology of what the scarred matrix does in an oncologic sense, though certainly plenty of good researchers are working on that, and some progress has been made. But go back to that genomic integration that we talked about, and that is hypothesized to be the mechanism behind non-cirrhosis related HBV-associated liver cancer, non-cirrhotic HBV-associated HCC. And the theory goes, although it may be a bit oversimplistic, that if the part of the genome that does integrate does it uncomfortably close to a tumor promoter gene, that you may activate it, or uncomfortably close to a tumor repressor gene, and you may suppress it, thereby eliminating the effect of the repressor gene. That, in a nutshell, is the wellspring from which a huge amount of literature has arisen and is continuing to be generated to this day. I want to share with you, particularly for those of you who are a bit younger, the most important natural history study of hepatitis B ever done. And this was done in 7 Taiwanese townships where over 3,500 HBsAg positive people were identified and followed for a mean of 13 years, the data from which resulted in 2 classic papers that I want to quickly share with you. Those papers showed us that, as one might have expected intuitively, but really had not been demonstrated before, that the viral level at the onset of the follow-up period at time 0, when the patients were first identified, was directly related a mean of 13 years later to the downstream risk of liver cancer. The higher the viral level, as you see in the color key, the greater the risk of cancer. And if there's an inflection point here, it's really at the 2,000 IU per mil level. Back in those days, the viral level was measured in copies per mil, but now we do it in IU per mil. And the ratio is about 5:1. So in that paper, if you were to look it up, you'd see that they're really talking about copies per mil, but I've given it to you in current parlance as 2,000 IU per mil here, where that inflection point is. And the same was true in the preponderant E negative cohort, which comprised over 75% of the cases, which tells you a lot about the fact that the majority of patients in our practice with chronic hepatitis B are in that E negative state that I already talked about. As I'll show you in a second, the same theme emerged from studies of cirrhosis after those 13 years, where again, you see an inflection point at about the 10,000 copy or 2,000 IU level, but then higher and higher as you get to ever higher levels of virus. And remember, those are HBV DNA levels at a single point in time. So what this shows very powerfully in these two classic papers is that a single HBV DNA level early on in the patient's subsequently followed course, was powerfully associated with the risk of these bad downstream outcomes. The most important part of the table, for those of us who tried to extrapolate these data to a formulation that we could use as guidance for clinical management, was this table, which showed that not only was the initial viral level very important, but what that viral level did spontaneously, this study dating to an era before the first HBV therapies had been used, lamivudine, the first oral agent, which was developed in the late 90s, that the degree to which the viral level dropped was actually related to the relative risk of subsequent hepatocellular carcinoma. And I dare suggest that the same would be true if you did this analysis for cirrhosis. But with liver cancer being the most feared outcome of HBV, this particular paper was mostly about liver cancer. So again, the patients who started with the highest level of viremia and stayed high had the greatest risk of HCC. Well, for clinicians who looked at and analyzed this paper all those years ago, it's already about 15 years, we took away a very strong implication from this, that if we could lower the viral level pharmacologically, rather than try to watch it passively by natural history, perhaps we would get the same benefits to the patients. And no study more than this drove the much more widespread use and expansive thinking about who ought to be treated for chronic hepatitis B than this study did. We continued to learn things from this classic study even after that, those two classic papers came out. If we look at patients with persistently normal ALT levels, starting at year one, but persistently normal, we can see that a normal ALT did not guarantee you against adverse outcomes and was still related to some extent to the initial viral level, as you can see. More so in the E-positive patients here, there was a greater cumulative hazard, at least of chronic hepatitis and sometimes clinical events, than to take the other extreme, patients who were E-negative and had lower viral levels of less than 2,000 IU per mil initially, and then a group in between, as you can see. And then one of the last major papers that came from this very famous study depicted the progression of HCC and liver-related death in so-called inactive carriers with lowish viral levels and putatively normal ALT levels, though we argue to this day about what a normal ALT is. And you can see that bad things in the form of HCC and liver-related death happen more often in the so-called inactive carriers than in patients who didn't have the HBsAg carrier state at all. So these kinds of data have also played importantly into our thinking that maybe we shouldn't limit treatment only to the patients with very high viral levels, and possibly not even limit patients to those with elevated ALT levels, which our guidelines, as I'll show you, continue to perpetuate. I think the most famous therapy study, as opposed to natural history study ever done, was this one from Professor Liao, a very famous Asian hepatologist, reporting this paper in the New England Journal in 2004, comparing placebo to lamivudine in a 2-to-1 ratio, drug versus placebo. The Data Safety Monitoring Board for this study famously actually stopped the study after less than 3 years in what was an intended 5-year study, because they began to see statistically significant differences to p-values of less than 0.05 for each of these clinical endpoints, Child-Pugh Turcotte score increases, and HCC, perhaps most resoundingly HCC, more common in the placebo recipients after a mere 3 years in the lives of patients who were a mean of 42 years old in this study, most of whom had presumably been infected lifelong given their Asian descent. Now, this p-value was 0.047, and to the dismay of many of us, some seized upon that as inadequate evidence that this study was delivering the powerful message that we thought it was about antiviral therapy being a good idea for many more of our patients than had hitherto been thought of as treatment candidates. Now let's talk about current HBV treatment guidelines, and I'll start just with a reminder, particularly to our younger colleagues, about what you should check in an HBsAg positive patient. So obviously you've done a liver panel, always check an e antigen and antibody, always get a viral DNA level by quant PCR. The genotype is optional. Dr. Martin and I were on a panel and have co-authored an algorithm together 5 times over. We're very proud of ourselves. Back in 2006, when we became the first guideline or algorithm to suggest mandatory testing of genotype. I have to say, as one of the people who really pushed for that, I've already told you that it's really not essential to management of most of these patients, but I still do it. We've come to think, and I'm not going to talk about Delta or hepatitis D virus really after this unless you have questions, but we always check. Many of us have come to think that with the now noted prevalence of hepatitis D in B patients, remembering that Hep D only occurs in people who have Hep B and often makes the disease worse, that the prevalence in the United States in our B carriers is about 5%, which many experts, including myself, currently think is enough to warrant a one-time hepatitis D antibody test, the most useful serologic test. Don't bother with a hepatitis D antigen test, even though it's available. And then always check a D RNA level if the antibody is positive. We're trying to get this as a reflex test, like we have with hepatitis C, where you don't have to order it twice over and wait for this result to come back before you order the second one. I always check my patients for hepatitis C as well. I like to get baseline AFP. Baseline imaging is important, and you'll see why as we go along. And of course, hepatologists nowadays love our transient elastography or so-called FibroScan machines because it gives us a real-time, very convenient, simple, cheap in-office way of assessing, at least getting a ballpark idea of where the patient's scarring status or fibrosis status is at. These are the only drugs you need to know about. Tenofovir comes in 2 forms, the older TDF, tenofovir disoproxil fumarate. Glad I got that out. And that's a 300 milligram dose of tenofovir, and the more recently introduced one, tenofovir alafenamide, which is only 25 milligrams, but has a carrier that more efficiently gets it to the liver and avoids the kind of systemic exposure that causes some of the very few side effect concerns that we had with TDF. Entecavir is the other very potent drug, and both of these drugs are essentially and marvelously impervious to resistance developing in the hepatitis B population of the patient's body, as opposed to the older drugs like the aforementioned lamivudine, which was very susceptible to resistance and usually became useless after 4 to 5 years of use in the old days. I mentioned interferon because all the guidelines continue to list it as a first-line drug. But I've crossed it out here because for all practical purposes, certainly in this country, most hepatologists would rather not use interferon. It does have the ability to clear e antigen after 1 year in a little bit more than the drugs here do, the nucleotide or nucleoside, which are almost the same thing basically, except this has a phosphate group and this doesn't. Peg interferon for a year can clear e antigen, which is a major goal of therapy in E positive patients, in about 30% compared to about 20% with the oral drugs. But what I've always told my trainees is I'd much rather take one of the oral drugs for 3 or 5 years or even forever than take a year of interferon. We can debate that, but this is the pattern of use in the country now. So these are the 2 drugs from my point of view that you need to know about. And just very quickly, I want to show you some data from the very important pivotal trials of TDF versus TAF showing identical levels of viral suppression in both E positive and E negative patients. Those curves are superimposable. And this reflects the safety concerns we had with TDF over the years, which is that there was a slight, but perhaps not negligible, reduction in eGFR in large patient populations, though the creatinine itself wouldn't necessarily change in every or even many individual patients. There was a little bit of a drop across the populations that were studied that we really didn't see with TAF. And so that became one less headache to worry about, even though it seldom materialized as a clinical problem, even with TDF. And the same problem with bone density, whether hip or spine. And you can see the differences here. So most of us have figured over the ensuing years since TAF was approved in about 2016, that since they're equally effective from an antiviral potency viewpoint and similarly impervious to emergent resistance, that, why not go with the nicer curves here and subject your patients to an even lower risk than a drug that was really quite a marvelous drug and still is, but it had this one kind of defect in its armor. Again, the approved drugs work as you might expect a nucleotide or nucleoside analog to work. In the phase of viral replication, where the viral genomic material is being replicated either by reverse transcription from the pre-genomic RNA that I mentioned before, or from the initial single strand of DNA to the second strand of DNA, the HB polymerase is inhibited by these so-called chain terminators, the tenofovir and tenofovir, which are very potent, render about 70% of patients DNA negative after a year and increasing numbers after that, again, without the burden of worrying about emergent resistance. Interferon has both antiviral and immunomodulatory properties, the latter of which account for most of its side effects. This particular slide makes it look like the only effective interferon is immune modulatory, but it has important general non-specific, that is non-specific with regard to hepatitis B antiviral properties as well. I've sat at panel discussions as recently as 2 months ago where some of the leading scientists in the world continue to debate to this day how much the efficacy of interferon in hepatitis B was mediated by antiviral effects as opposed to immune modulatory effects. And we still don't have a pie chart that we can draw for you to say it's exactly this percent one and this percent the other. The American Liver Association guidance on HBV therapy divides the guidance into, as all of our guidelines have, into E positive and E negative patients. Now, bear in mind what I didn't mention before, which is that E positive patients tend to have a log and a half or 2 log greater levels of virus. They're the patients who can get up into the hundreds of millions or even billions of IU per mil, particularly in patients early in their course who have the so-called immune tolerant state. And in one rendition after another, as recently as 2018, and I wouldn't be surprised if revisions of this are being updated now, the cutoff for treatment candidacy has been 20,000 IU per mil. Very few patients who are E positive have levels below this, although a few do, and I think it's kind of arbitrary not to consider them treatment candidates, as they acknowledge here in the gray box. Your ALT also to be a clear-cut treatment candidate, as shown in purple, where it's the only group here that they say is definitely a treatment candidate, is your HBV DNA has got to be above 20,000 and your ALT has to be above twice normal. This has made many hepatologists very unhappy. I think of it as a relic of the 1990s when people didn't respond to interferon very well unless the ALT was indeed significantly elevated. And that may be true to some extent even with the nuke analogs. But the fact is that you can get marvelous viral suppression no matter what the ALT is. So many of us wish that this twice normal thing would go away. But the ASLD guidance, which I have to acknowledge is authored by some of the leading and most respected hepatologists in the world, and the respect comes from me too, even if I'm not entirely happy with this continued adherence to this twice normal cutoff. I'd certainly want to get treated if my ALT were 60. It doesn't have to be 80 or 100, but enough of that. What I want to get across here is that they have all kinds of gray zones here with intermediate levels of virus and intermediate levels of ALT elevation from upper limit of normal to twice normal, where they say, look at some other things, including, importantly, inflammation and fibrosis. But they insist on having quite a bit of fibrosis, moderate fibrosis or more, or a lot of inflammatory activity to treat these patients. And for many of us, that is no longer the inflection point, given the ease of use and robustness of potency and lack of resistance associated with the drugs that we have. The E negative guidance says the same thing, except that 20,000 becomes 2,000 because the E negative patients, as I mentioned, run lower viral levels. But here again, the only really clear-cut treat immediate candidates in their view are 2,000 for the HBV DNA and twice normal or above for the ALT. This is a very recent paper just from a couple of weeks ago that I found that really crystallizes what the AASLD guidance says. which is that these should be the cutoffs, that the only clear-cut indication is 20,000 and twice normal, unless you have moderate necroinflammation or fibrosis. That's what all those gray boxes in the previous ASLD chart or diagram that I showed you were trying to indicate, but I think it's shown very clearly here. Now I'll come to my favorite treatment algorithm of all, and you can see that there is some bias here, both with regard to the first author and the last author. A great hepatologist, the late Emmett Keefe, put together a group of us in 2004, and we felt that the society guidelines, which are necessarily very evidence-based, as society guidelines need to be, left room for expert opinion in some of the, to use it again, gray zones where there might not be clarity in the literature. So we put together an algorithm back then that has gone through 5 renditions. And unfortunately, Dr. Keefe passed away a few years ago, and my dear friend, Dr. Martin, took this over. And together we've co-authored this paper that just came out online. And we make it very simple for clinicians. We say that if the HBV DNA is above 2,000 and your ALT is above normal, as we define ALT now, which is lower than what your lab is telling you is a normal ALT, by the way. The American Liver Association says now that a normal ALT is 30 for males and 19 for females. But the recent ASLD publications have ratcheted that up to 35 and 25, which I think is better. In any case, we make it very simple. High DNA above 2,000, any elevation in ALT, go ahead and treat with one of the preferred agents that we talked about. For compensated cirrhosis or decomp cirrhotics, we basically say treat all of them. We certainly don't want them to have a flare, as hepatitis B patients can have, because that can be very dangerous. It can result in some necrosis on top of already existing cirrhosis and throw the patient over the edge of a cliff. So we say treat any level of viremia. We also don't want any viral replication in those patients. And these are the treatment endpoints, what I call the traditional view, where in E-positive patients, the most cherished outcome historically has been loss of E antigen, usually with concomitant appearance of E antibodies. So we call it E seroconversion and stop 12 months later. But if you don't seroconvert or lose E antigen specifically, you're guaranteed to have viremia relapse if you stop treatment. So don't stop treatment, treat indefinitely, particularly with the nucleotides. You can't do that with interferon. We say don't stop in cirrhotics, even if they do have seroconversion. And nowadays, many of us feel, based on a little bit of literature, that you may be better off in terms of preventing viremic relapse if you go out, say, to 36 months as opposed to 12 months. So I take my sweet time stopping my patients. I don't stop after a year anymore. For the E-negative patients, the historical view has been very simple. Treat indefinitely unless there's S loss, and don't stop in cirrhotics. Even if you choose to stop, or if you have a patient who wants to stop, you should be really emphatic about continuing. But now there's a controversy about whether we can indeed stop, and I'll touch on that in just a few minutes. But whatever you do, don't stop in cirrhotics until and unless they lose surface antigen. And even then, if I can use the phrase again, I take my sweet time stopping until I'm really sure over a year or two that the S antigen is gone for good, which it usually is, happily. One of the big controversies is whether to treat the so-called immune tolerant patients, which every society guideline in the US, Europe, and Asia say thou shalt not treat immune tolerant patients. And the basis for that is that there's an admitted very slow rate of progression over a 5-year period if the patients remain immune tolerant by their laboratory markers. And also because if E antigen clearance is your major goal, it is true that there's no therapy that gets many of these patients to clear. But to many of us, the be-all and end-all of therapy has become viral suppression, not E antigen clearance. Now, we admit in this study that compared TDF to combination therapy with FTC, that E conversion indeed seldom occurs. So if that were your goal, you're wasting your time. But if you look at it, it's true certainly that none of these patients lose surface antigen when you treat them, and not as many clear the virus in terms of even at a 4-year time point here as they would if they were so-called immune active, but they all profoundly suppress virus, as you can see by these log reductions of over 6 in both the single therapy group and the combination group. So some of us renegades have adopted the position, for reasons that I'll try to justify further in a moment, that we should in fact treat these patients now that we have drugs that won't engender resistance. Here's a famous study from Korea that looked at 413 immune tolerant patients, nearly 1,500 immune active patients on treatment. The immune tolerant patients were left untreated. And over a 10-year period, more adverse outcomes occurred in the patients who were immune tolerant, shown in blue, whether it was HCC or death/liver transplantation, or in the immune active patients. Now, there were certain methodologic limitations in this study, including the fact that their average immune tolerant patient was 38. And the ones we really worry about are the 20-year-olds and the 25-year-olds. So admittedly, that's not this population. But I looked at this and it further confirmed my already growing feeling back then that we should be treating these patients. The real change in our thinking came with this paper several years ago of 26 patients, sorry about the blank here, which included 9 immune tolerant patients. This is a very elegant study looking at liver tissue for viral integration and clonal expansion of liver cells. And they found, first of all, that there was a high level of DNA integration randomly distributed amongst the chromosomes in all 3 groups, getting back to that theme of integration that I mentioned before. There was a lot of clonal hepatocyte expansion, even in the immune tolerant patients, which conceptually at least might be a precursor of carcinogenesis. And there was actually some immune activity that they could show in vitro studies of T cells. So the authors said, let's get rid of this term immune tolerant and call it high replication, low inflammation phase. But most importantly, they said, and I quote, withholding of antiviral therapy in immune tolerant patients requires reconsideration. Then came 2 studies very elegantly looking at paired liver biopsies from treated patients at the annual liver meeting last year. And I think I'm going to skip over the details in the interest of time. But basically, these authors showed that in paired liver biopsies, pre and post-treatment, that expressed viral integrations were associated with low viral load. This one was not pre and post-treatment. This was just to look at the livers of these chronically infected patients. That integrations were associated with positive or negative markers of host gene dysregulation. And in the treated patients, indeed, a reduction in viral load with TDF was associated with reduced integrations and expression of dysregulated genes. This one really took the cake. It was a smaller study of paired liver biopsies in a group of treated patients, showing a marked reduction in the median clone size after 1 year. And most dramatically and really surprisingly, of 5 patients biopsied at year 10 of treatment, 3 of 5 no longer had detectable viral integrations, which you always find in untreated patients. So that was really it for me. I slapped my hand on my knee and I said, I've been right treating these patients for the last 3 or 4 years. And my plea here is that there, in light of a variety of lines of evidence suggesting that these biologic events that are associated with Hep B may be pro-oncogenic, and that we have safe and effective medications that are not free, admittedly, but generally free of side effects in the long term. And in light of the psychosocial and public health implications of having a 25-year-old walk around expressing 500 million IU of virus per mil and being highly infectious, and generally the principle that years of high-level viremia can't be good for anyone, isn't it time, I would ask, to allow in the guidelines, evidence or not, to their liking, or satisfaction, I should say, to allow for individualized decision-making, and instead of making it verboten, leave it up to the patient and the clinician. And there's a difference already between the AASLD and the European guideline. The Europeans say, treat if over 30 years, regardless of the severity of liver histology. The AASLD says 40, and you've got to have real disease, which obviously I take the much more expansive view here. I haven't made any secret of my opinions about this. I'm going to skip over this, except to please remember that if patients are going on chemo, they should have HBV serologies checked. And remember that rituximab and other CD20 inhibitors, as well as patients undergoing procedures that will result in profound immunosuppression, should be prophylaxed, even if they, quote, only have anti-core and don't have HBsAg, because they still harbor small levels of CCC DNA. Now I'm going to skip over these. I'm going to make one plea for screening all of your patients who meet the AASLD criteria as shown here for HCC, with at least ultrasound, with or without AFP every 6 months. In their view, the AFP has become expendable, and I think imaging is indeed much more important. But I have issues with this too, because in every large Asian series of HBV-associated HCC, anywhere between 9 and 12% of very large series of HCCs associated with B are under 40. Like in the previous study, here's a study from Bellevue, not so far away from where I'm sitting right now, from a few years ago, large collection of B-associated HCC patients at Bellevue, 93 patients. almost 20% under the age of 40. I, for one, screen all my adult patients, but I readily admit that the yield is low and I might not make it past somebody's cost-effectiveness analysis. We use plenty of cross-sectional imaging as well as ultrasound. You have to, after all, if you get a report back from a radiologist that says, this cirrhotic liver really cannot be well visualized with ultrasound, you're on the hook, really, to do a CAT scan or MRI once in a while to screen that patient's liver. And these are the kinds of differences in sensitivity for small HCCs that this study, for example, have yielded when you compare MRI to ultrasound. With regard to whether or when we can stop nucleotides in E-negative patients, remember you can't stop in E-positive patients because their viremia will relapse. There was a paper from Greece a few years ago by a wonderful hepatologist who now is no longer with us, that if you stop therapy after 5 years of viral suppression, interestingly, more of the patients subsequently cleared S antigen than they would have had they been left alone, according to all historical comparisons. And this small controlled trial from Germany actually randomized patients to stopping or continuing after years of viral suppression, and actually showed that some patients in the stop group did lose S, but none in the nuke continuation group did. So this has spawned a cottage industry of all kinds of studies looking at stop nucleotide therapy. And it's based on this premise that we know that the chronic carrier state is attended by immune exhaustion with expression on T cells of all kinds of markers of immune suppression like PD-1 and other inhibitory receptors. And the idea might be that with prolonged nucleotide therapy, when you suppress viral replication and hopefully suppress surface antigen, which we think is an immunosuppressant that promotes viral or ongoing viral replication, or at least persistence, that allows some of those exhausted T cells to wake up. And you really let them wake up and do their thing, so to speak, when you take patients off their nuke therapy, let the virus reappear, and then with a bang, the immune system comes roaring back, having awakened somewhat from its slumbers. And that's how you might clear the surface antigen more expeditiously if you stop therapy. The guidelines from ASLD, which I generally agree with, still say in E-positive patients, go for at least 12 months. I've already told you I go to 3 years. Don't stop in E-negative patients. But the European and Asia Pacific guidelines have grabbed onto this new idea and say, well, you can individualize stopping decisions if after 2 or 3 years the patient has been completely virally suppressed. This interest has been fueled further by studies like this one from Asia, showing that the level quantitatively, most of you are probably not used to ordering quantitative S levels, but the quant level of surface antigen, if below 100 at the end of a course of therapy or potential end of a course of therapy, is quite predictive of a much greater chance of subsequently clearing surface antigen, attaining what we call functional cure, than these higher levels here, particularly for over 500 IU per mil. A beautiful algorithm was just published showing that there may be a difference in this regard between Caucasian and Asian patients, probably not based so much on genetic factors, but the time in life when the infection was acquired. And for our vastly preponderant Asian patients with hepatitis B, that number where people propose that you have a decent chance of clearing S if you stop is 100 IU per mil. In Caucasians, these authors of a very large study that broke all this down said 1,000 may be a better cutoff. My takeaway is that I continue to treat most of my patients, but I do think based on quantitative S determination that you can have a decision, a discussion with the patient about the pros and cons of stopping. My warning to my colleagues is that a decision to stop should be as much patient-driven as clinician-driven, because if you browbeat, so to speak, a patient to stop, saying you've got to stop, it's perfectly okay to stop, nothing can happen, you're wrong. And very bad flares can occasionally occur that can make patients ill, particularly, but not only if they have more advanced liver disease. So if you tell a patient it's fine to stop in this group of patients who've had longstanding viral suppression on nukes, and they have a bad flare, you kind of own it, as I like to say. Now, I'll finish with a very brief discussion of novel therapies. And the next step in the field is the attainment of what we call functional cure, which is the appearance of anti-HBs instead of surface antigen. We're a long way off, as you can see in my little pictures down here, to being able to eradicate the cccDNA or integrated DNA, certainly. And the main goal of achieving functional cure is that it enables you to stop therapy, make infinite therapy, I was going to say finite, but also there's a strong hint, particularly from some Asian studies, that people who actually clear surface antigen after having been chronic carriers do have fewer adverse outcomes than those who remain persistently surface antigenemic, as shown down here, where if you look at hazard ratios for adverse outcomes and complete viral suppression for persistent S antigen as the reference, incomplete suppression does worse, but clearance patients do a lot better. So this is a desirable goal, and these are the new treatments in the pipeline, ranging from entry inhibitors, remember that bile acid receptor, and we have one now that's being studied, things called nucleic acid polymers, which impair the release of surface antigen and have had some very dramatic effects that I won't share today. We already use polymerase inhibitors, and I'll just show you a wee bit of data on the capsid assembly modulators and the inhibition of protein translation agents. This is just to show you the life cycle again and to suggest to you that capsid assembly inhibitors might not only inhibit primary capsid formation, without which the virus can't replicate its genome, but might also inhibit this secondary phase in the life cycle where, as I said before earlier in the talk, the virus DNA is replenished within the nucleus as integrated DNA because some of it goes back here instead of being packaged into whole viral particles and going out of the cell. And believe it or not, disassembly actually can be inhibited, I should say, by capsid assembly modulators, just as assembly itself can be. So maybe it's a double whammy if you give a potent capsid assembly modulator. And this gives you an idea of the added level of viral suppression when you add a capsid assembly modulator to a nuke like entecavir. This is the entecavir curve, and you get a log and a half more viral suppression in half a year if you add a capsid assembly modulator using very sensitive HBV DNA assays. But you don't get surface antigen clearance, which was supposed to be the whole point. So you're
going to have to stop in 30 seconds, Dr. Jacobson.
Okay. So then I'll show you the last thing, which is that they don't work, at least the ones so far. The less potent agents don't work in the long term. We now have follow-up data. And just to give you an idea of what small interfering RNAs do, they profoundly suppress the expression of surface antigen with a very delayed rebound, which is very interesting and we're still trying to figure out after you've given a few early doses here. And this is fascinating because we think that by suppressing surface antigen, you release that hitherto suppressed immune response and might help the patient clear surface antigen. And I will just let you peruse my concluding slide in the interest of time and out of respect for Dr. Weiss.
Dr. Jacobson, thank you very much for this extremely interesting, made sense, logical presentation of what we really need to know about hepatitis B virus infections. I'm grateful. I hope we get an opportunity to greet you in person at some point. I know Dr. Goldberg had one quick question, which will allow him to ask. David, unmute yourself.
Sure.
And
so I guess, Ira, thank you for the talk. Have you had problems with insurance approving Hep B therapy in patients that don't meet the ASLD guidelines, like just the high DNA level, but normal ALT?
Well, David, the first thing I want to say is it's nice to meet you, so to speak. I have congratulated Paul many times over for stealing you away from Penn because for everybody else, I think you know this, but Dr. Goldberg is one of the rising superstars in the field of hepatology. So that's the most important part of my answer to you, David. My answer is that in my practice, I don't have trouble getting coverage for those patients. In the rare instances when I do, I've generally waged the good fight and I've been able to get these patients covered. You know, as you know, the cost of these drugs is not as big an issue as it used to be. And if I can't get TAF, for example, I'm happy to use TDF or entecavir, for which there aren't major issues with cost and insurance carriers these days, at least around here.
Thank you very much, Dr. Jacobson. I wish everyone a happy, healthy new year and look forward to seeing you healthy in the coming weeks. We will have a Department of Medicine update fireside chat next week. Look in your emails for details regarding that, just to update everybody on the COVID situation. There is a town hall meeting tomorrow night. Those of you that can make it, you'll have seen the advertisement for that. Wishing everybody well, and thank you so much again, Dr. Jacobson and Dr. Martin, for inviting Dr. Jacobson here.
Thank you.